Well, good morning, everyone. Good afternoon, good evening, good night, depending on where you are in the world. This is our third international webinar this year, and I'd like to welcome you. My name is Mike Cohen. I'm president of the Institute for Safe Medication Practices. As I said, it's our third webinar this year, and this time it's on human factors and medication errors. This educational program is going to explore human factors and the role it plays in medication safety. And our speaker is Judy Smetzer, a nurse that I've worked with for many years. She's a vice president here at the Institute for Safe Medication Practices. And she's first going to review human cognition and the cognitive tendencies and biases that influence human behavior, including confirmation bias, inattentional blindness, hindsight bias, normalcy bias, and several others that many of you probably have never heard of before. But that's the point here. We're going to teach you about these. I've worked with Judy for many years. Judy and I do the ISMP newsletters together. Judy was a fellow with us back in the 1990s and then stayed on at ISMP. I'll give you a little bit more info on Judy in a minute. The focus of today's webinar, it's on the conditions, both human and system, that degrade human performance and the strategies to reduce their impact on patient safety. So I think you'll find it interesting. Judy's also going to review human-centered system design strategies that can improve medication safety. She'll speak a little more than an hour, and then we'll end with a question and answer session. And by the way, you can ask questions via the Q&A button that's at the bottom of the Zoom screen. Many of you are familiar with that. Some of you may use the chat, but we'd rather use the Q&A. We'll keep both open though if you want. You can run that chat during the webinar, not a problem. But let me introduce Judy right now. She first joined ISMP actually in 1997. She was a ISMP Safe Medication Management Fellow. Judy's an RN, she's a nurse. Our fellowship program has both nurses and pharmacists. We would take physicians and other health professionals as well. They were qualified for the program. She completed a one-year program with us, and that provided training in adverse drug event prevention and management. And since completing her fellowship, as I said, she stayed on with us and has served as one of the primary authors and editors of our newsletters. We have 5 newsletters altogether. One that you may be familiar with if you're in hospitals is the acute care newsletter, but we also have them for nurses, community pharmacies, long-term care facilities, and also a newsletter for consumers called Safe Medicine. Judy has worked with various teams at ISMB to conduct studies associated with medication safety funded by the Agency for Healthcare Research and Quality here in the United States. That's a federal agency, and also the U.S. Food and Drug Administration. And we've done ISMP medication safety self-assessments for high alert medications, for example, through an FDA grant. And also the ISMP medication safety self-assessment for perioperative settings, which we are going to be releasing very, very shortly. Been working on that. It's going through pilot testing right now. Judy's also a certified trainer in just culture, and she's presented to various healthcare audiences on the topic and many others related to human factors. Also, highly reliable organizations is a subject that she's written about and talked about, and medication safety in general. Her work in these areas really has helped many healthcare organizations understand the human behavior behind medication errors and why the second victims of adverse events require and deserve psychosocial and professional support. Those are the people involved with the error itself, not the victims of the error. The American Public Health Association honored Judy with a 2002 Abitus Donabedian Award for her work in medication safety. And in 2012, she was awarded a Waypaver for barcode point of care from the TerraPharma project. In 2013, Judy was the first nurse recipient of the American Society of Health System Pharmacists, that's ASHP's Board of Directors Award of Honor. I believe she's still the only nurse given that honor, and that was quite an honor. ISMP does want to thank Novartis, Name Creation and Regulatory Strategy Departments for supporting this program and it is totally free of any commercial interests. We greatly appreciate them doing it because it allows us to do this live and for free. And we also will tape it. So those of you that have colleagues that may have missed this program, you'll be able to go to our website and listen to the program online. With that, I'm going to turn the program over to Judy Smetzer right now. Judy?
Thanks, Mike, and good afternoon, everyone. My topic is human factors and medication errors. And this afternoon, I will be, as Mike mentioned, I will be talking about, well, first I'll be describing how the human brain works and the conditions that worsen human performance. And then I'll review some of the perceptual and cognitive biases that help explain why we as human beings make errors. And then I'll end the presentation by providing examples of how you can apply human factors to the design of systems to reduce the risks, particularly related to medication errors. So when an error happens, when a medication error happens, there's usually two components, a system component and a human component. Something in the system went wrong that allowed a human being to make a mistake. The human-based causes of errors are usually called latent failures. And latent failures are these weaknesses in the system that often lie dormant only to rear their ugly heads when combined with human fallibility. They're kind of like the holes in the Swiss cheese defenses of our healthcare systems. But there's also a human contribution to most errors caused by human error, at-risk behavior, or reckless behavior. The human contribution is usually referred to as the active failures of people. So there's people involved in those human contributions to errors. At-risk behaviors and reckless behaviors are risky behaviors that we make that set us up to make errors. So we might, for example, choose to bypass a barcoding system because it was hard to scan that barcode the last time. That would be an example of an at-risk behavioral choice that we make that might set us up to make a mistake. And then if we choose to work under the influence of drugs or alcohol, it might be a reckless behavior. But today our focus is going to be on human error, which is totally inadvertent. It is not a behavioral choice. Human error is inadvertent, and it's going to be the topic of our conversation today. So human error is defined as the failure of three key processes that are basic to human behavior. It's a failure in how we perceive information, how we think about that information, how we behave or execute our plan of action. So how we perceive information using all of our senses, if we have a failure in that process, it's called human error. How we think about the information we perceive and how we interpret it, how we plan to use that information. If we have a failure in that, it is also human error. And then if we have a failure in how we behave or execute our plan based on that information, it is also called human error. There's a large body of evidence that documents how often we as human beings make mistakes. So we don't have to guess at how often we make mistakes. It's repeated studies over and over again. And I just have a few examples on the screen here. If we start at the bottom of the table, humans function better as a team member than as an individual because we can capture each other's errors within a team. So at best, the best we can do under ideal conditions is to make 1 in 100,000 errors as a team. As an individual, the best we can do for well-designed, familiar tasks under the most ideal conditions is to make 4 errors in 10,000 attempts. So this would refer to the random human error that happens to everyone, those unexplained mental slips and lapses that we all are prone to. But as we add negative performance shaping factors to the mix, our error rate goes up significantly. So if you look at those that are listed at the top here, For example, if we try to select an ambiguously labeled package, let's say a medication package, we have a 5% rate of error. If there's a complex task that requires high comprehension and skill, which has a lot of steps in it and requires some specialized training, we have a 15% rate of error. If we throw high stress levels in, we might have a 30% rate of error. And if we ask someone to perform an unfamiliar task at speed, and we don't have any conversation about the consequences of an error, we actually have a 50% rate of error. And we in healthcare throw our new staff members at unfamiliar tasks sometimes and ask them to do it quickly, and we can expect a 50% rate of error. The point is that we make errors as humans frequently. Most of them are inconsequential, but a few are life-changing, and there's a large body of evidence that explains how often we as human beings make mistakes. Sorry. In order to understand human error, we need to understand how our brain works, and that mistakes are really the penalty we pay for our remarkable cognitive abilities to process large quantities of information, even if we have competing demands on our attention. So I'd like to review some examples of how our brain works, and we're going to start with the modes of cognition. So our brain basically functions in two modes of cognition, a automatic mode of cognition and a problem-solving mode of cognition, and a mixed mode in between the two. The automatic mode of cognition is often called absent-mindedness or brain system 1 or subconscious brain, and it's where we process information quickly, subconsciously, without giving a lot of thought to it. The problem-solving mode is often referred to as present-mindedness or system 2 brain or our conscious thoughts. But unfortunately, we spend about 80% of our waking life governed by our automatic mode of cognition, by almost an automatic pilot. So it allows us to manage large amounts of information, but we're sometimes working within a mental fog, so errors are quite possible. We're not thinking about our actions, we're making decisions subconsciously, we're not giving a lot of thought to it. It's why we can walk and chew gum at the same time. So we have to have that ability to function in the automatic mode of cognition. It's a compensatory mechanism so that we can do several things at the same time. But it also sets us up to make mistakes, and things like walking into a room or forgetting, or getting into your car, intending to drive to the grocery store and realizing that you're halfway to work on a Saturday and you didn't intend to go there. Or even more scary, driving all the way home and not remembering being in the car and how you got there because your thoughts were elsewhere. Or putting the salt shaker in the refrigerator or syrup in your coffee. Those types of slips and lapses happen all the time when we're functioning in this automatic mode of cognition. But most of the time, we're very effective. It's remarkable the amount of information that we can take and process in our brain in the automatic mode of cognition. It's effortless, and does set us up to make errors, but most of them are inconsequential. Unfortunately, the more experienced we are, the more we tend to function in the automatic mode of cognition. So as we learn a new skill, you can see that a functional MRI shows a lot of our brain is lighted up and working so that we can learn a new skill. But as soon as we learn that skill to the point of it being automatic for us, it's a routine for us, we reduce our load on the working memory by 90%. You can see we're not using a lot of our brain. We're functioning in the automatic mode of cognition. This is an automatic transition to this automatic mode of cognition. So it's not like we have a lot of control over it. Once we learn a skill, we then function in the automatic mode of cognition. So once you're an experienced practitioner and you have a lot of experience working at certain tasks, they all are functioned in the automatic mode of cognition. One of the interesting things to know about functioning in the automatic mode of cognition is that once we learn a task to the point of it being automatic, it's really hard to unlearn it. So if you have ever experienced driving a manual transmission car, for example, for a period of time and then switch to an automatic transmission, your foot always goes to the clutch that isn't there anymore. It's just hard to relearn tasks that have been done in the automatic mode of cognition. Now, we don't always function in the automatic mode of cognition. Sometimes we're functioning in a mixed mode. And if we're trying to learn a new skill or trying to face a new situation that we have received prior training to handle, we might apply a rule. That's actually the term that's used in human factors, applying a rule. But we can set ourselves up to make mistakes if we apply the wrong rules. So if I were to ask you to solve this problem, you may think the answer is 5 if you don't remember the rule is to do the division and multiplication first in the absence of any parentheses. Or the correct answer is 9, by the way. Or we might apply the wrong rule. So we might program a new infusion pump based on how we programmed previous infusion pumps, but it might be totally wrong for that infusion pump. We might prepare a new admixture or a new medication or a vaccine the way that we've always prepared it, but there's different rules. There's overfill in this one that is different than the others, and the mixing components, the diluents are different, or there might be a second component to the vaccine. So this is where we might apply the wrong rule. Now, just going back to this equation, if we did the division first, 2 divided by 2 is 1, and then we add 1 to 3 plus 5, it equals 9. So the division comes first. Someone just asked that question, so I thought I would just quickly answer it. When we're trying to locate or identify something in our environment, we move to this mixed mode of cognition, and we use a process called pattern matching, where we pull a picture or sensation, like a smell, from our memory, and we scan our environment looking for the desired item, or we're trying to identify a certain sensation, etc. We use pattern matching for this process, and it's essential to make sure that we're efficient and expeditious in our tasks. Can you imagine reading the name of all the books on your bookshelf instead of scanning for that small red book that you're looking for? But pattern matching requires that you look for certain information, that you prioritize some information, like that small red book, while downplaying other information. So if you're looking for a specific medication vial and you have a picture of what it looks like in your mind, you might be looking for that small vial with a light blue cap with a blue and white label. The problem here is that pattern matching can lead to confirmation bias, where we look here, or we prioritize certain information, downplay the other information, and we miss seeing information that is actually there. So confirmation bias is selectively searching for information that confirms one's beliefs and rejecting information that does not. So we see what we expect to see. And we literally can't see any disconfirming evidence that we might have misidentified or mislocated a particular product. It's also part of our human nature to judge the likelihood of being successful in our searches for different items by how easily it was to locate it, or how easily the idea sprang to mind. And we have this stubborn tendency to stick to our initial assumptions and not pursue any alternatives with disconfirming evidence that might say that what we have in hand is absolutely wrong. So yes, we can look for medications based on the vision that we have in our head. We can read the labels, but we tend to see what we expect to see, and it could be wrong. And we literally don't process that information that is disconfirming and tells us that we have selected the wrong product. So that is not such a big deal when you're confusing two cereal products at the grocery store. When you're scanning the shelves and you're looking for a cereal that has a yellow box and has a some type of monkey on it. But it is a big deal when you confuse different drugs just because they look very much alike, or different strengths of drugs, or different syringes that contain different medications. That can be a huge deal. So confirmation bias leads to grabbing that Pepsi instead of Diet Pepsi at the food store, as well as picking up the wrong product and never seeing that you have the wrong product in your hand, even if you have read the label. So we move into this deep problem-solving mode of cognition very reluctantly, only after we've failed to at least try to solve the problem twice and have failed. So we move into this synthesis analysis or analysis synthesis mode of cognition very reluctantly. And again, we have to fail at solving problems before our brain moves there. And this is because it's very slow and mentally exhausting, and but we're least likely to make mistakes given that we have the knowledge and aptitude to solve problems. So it's where we spend our time when we're pondering novel situations or doing complex computations, or really making sense of our world. And we have failed to solve that problem several times previously. So if you've spent a lot of time in this analysis synthesis mode of cognition, you're mentally exhausted at the end of the day. You might not be physically exhausted and not understand why you're so mentally exhausted at the end of the day, but you've probably spent a lot of time in this analysis synthesis mode of cognition. And remember, we go there very reluctantly. So if we put it all together, so if you're facing a routine situation, something that is highly practiced, you're going to be using skill-based behavior, and then you're going to be functioning in the automatic mode of cognition, kind of like a mental fog, and you're going to possibly make mistakes. If you're facing a trained for problem, you're going to be in this mixed mode of cognition, and you're going to be using rule-based or pattern matching types of cognition to try to solve that problem. But again, you might be prone to confirmation bias or applying the wrong rule at that time. So errors are still possible. And then if you're facing a novel problem and you have failed to solve it, you might be using knowledge-based skills and in the problem-solving mode of cognition. But just remember, we go there reluctantly after repeated failures. I also want to draw your attention to the fact that we move between these modes of cognition pretty seamlessly, and we could be functioning in all three modes at the same time with a specific task. Take driving, for example. The speed and direction you might be maintained using skill-based behaviors because it's routine and practice, and you might be in the automatic mode of cognition where you're coming out every once in a while for conscious checks of your speed and making sure that you're going in the right direction. But if you have to negotiate other drivers on the road that you might need to pass, or slow down for some reason. You might be using rule-based behavior and be in a mixed mode of cognition. But at the same time, while you're driving, if you're brooding about a very difficult problem, you'll be using your knowledge-based behavioral skills, and you'll be in the problem-solving mode of cognition. So you can use all three modes of cognition at the same time for specific tasks. In addition to the three modes of cognition, there's three basic components of cognition that we can liken to a computer. So we have a sensory register, a working memory, and a long-term memory. The sensory register is much like the keyboard of a computer. It's the gateway into the brain where we use all of our senses to produce an image or sensation, hold it in our brain in that sensory register for a short period of time to see if it's important enough to get into our conscious memory. So our working memory is our conscious brain. It's our operating system. It scans the sensory register and it assists with the conscious thoughts and deliberations. It's responsible for our decisions, our computations, and it's much like the operating system of a computer. And then we have a long-term memory, which is much like the hard drive of a computer. And this is where we store all of our memories. We code it first and sort it and store it and establish rules. If this, then that. So it's kind of like the hard drive, and hopefully we'll be able to retrieve those memories when we need them. There's certain processes that are going on in the sensory register, the short-term memory and the long-term memory. And these are called encoding, maintenance or rehearsal, and retrieval. Encoding refers to what happens when all of our senses bring information into the sensory register. We perceive that information, we bring it into the sensory register. It only is held there for 2 seconds, so it's a very short period of time. And information that is not attended to tends to be overwritten with new information that's coming into your brain all the time from your different senses. So unless the information is attended to, it decays and it's lost or overwritten with new sensory information. It's held there for a period of 2 seconds where your attention filter decides whether it's important enough information to allow it to get into your short-term memory. So remember, if it's not attended to information, it will be lost even though we're bringing it into our brain. Then the process is called maintenance or rehearsal when information is brought into our short-term memory. We do have some capacity limits there. We can only think about 7 to 9 pieces of information at the same time. So the short-term memory has limited storage capacity, as the name applies, but unless that information that is brought into the short-term memory is rehearsed, it's decayed and overwritten with new sensory information that's coming into the short-term memory all the time. So this is why we rehearse information, why we study for exams, etc. We're trying to make sure that we remember that short-term, that we're rehearsing that information so it gets stored in our long-term memory in a manner that we can then retrieve it when needed. So unless that information is rehearsed, it decays and is overwritten with new sensory memory information. And then our long-term memory, the process of retrieving memories from our long-term memory is called retrieval, as the name applies. Some theorists believe that the long-term memory decays over time, but most theorists today believe that it has unlimited capacity to hold our memories, and it's the retrieval loss, the retrieval mechanism that's lost over time with diseases like Alzheimer's or dementia or age. And it's not necessarily that the memories are lost, just our ability to retrieve it. So I'd like to cover each of these different parts of the brain, our sensory register, our short-term memory, and our long-term memory, and talk about what can degrade it, and talk about some of the perceptual and cognitive biases that happen. So first we're going to cover the sensory register. Remember, this is how we perceive information. We bring it into our brain, and the process is called encoding. So what can degrade our sensory register? Certainly things like sensory deficits. If you can't see or you can't hear or you have some type of impairment with your senses, you're going to impair your ability to bring information into your brain through those specific senses. But there also are system performance shaping factors and other personal performance shaping factors that can make it hard to bring information accurately into our brain. So system performance shaping factors are those factors that are in our external environment, things like physical distractions, light, noise, climate, humidity, glare, computer screens, etc. I like using this table here because it really shows how our performance drops as the heat goes up. And so there's things in our environment that can degrade our ability to bring information accurately into our brain through our sensory register. And there's also personal performance shaping factors. So not only those sensory deficits that we might suffer from, there's things like worry, fear, fatigue, stress, debt, job anxiety, etc., that might impact our ability to bring information into our brain accurately. We also, as humans, suffer from dozens of perceptual biases that impact the way we perceive things. I'm sure you've seen many pictures that form disparate images in the brain, depending on your viewpoint. This is just one that I have on the screen here. But we have already talked about one perceptual bias, confirmation bias, but there's dozens and dozens of perceptual biases that impact the way we perceive things. And there's the laws of Gestalt and different change blindness and confirmation bias, as we already talked about. But I'd like to talk about one that particularly helps us understand why people that are otherwise intelligent, diligent, and thorough fail to see what we think is pretty obvious. So why did a pharmacist fail to see that large red pop-up warning that everyone else seems to see? Or why did a nurse fail to see that big red orange sticker that said intrathecal use only? Why do intelligent, diligent people fail to see what in retrospect seems like it's pretty obvious? So when we confront people and say, why did you not see that? They often have no explanation, and they can only come up with the fact that maybe they just didn't read it and they overlooked it. There's usually no explanation. But there's a lot of examples that I can give you in everyday life and history where thorough, intelligent, diligent people seem to fail to see things that would be rather obvious to us. So for example, there was a submarine commander who surfaced into the belly of a ship, killing 9 people. At his captain's mast, several people testified that the captain clearly visualized the surface through the periscope. He turned the periscope around 360 degrees. He did it not only twice as he should have done it, but he did it a 3rd time and seemed to be very thorough. But at the captain's mast, they also had a human factors expert who testified that this was probably caused by inattentional blindness. Because the commander had never seen any ship above in his entire long career, the fact that he saw the ship this time was not attended to information that really entered his working memory. So it never entered his conscious thoughts. So although he saw the information, he didn't consciously attend to that information, and it didn't jump his attention filter. His mind thought it was useless information because after all, it's a very large body of water out there, and your chances of actually seeing a ship when you look through the periscope are pretty low. We also have an example of a woman who hit a young child on a bicycle. She had driven hundreds and thousands of times over a sidewalk into her driveway, and looked to the left and looked to the right and never saw anything. And this day she looked to the left, looked to the right, looked to the left again, and thud, she hit this bicyclist that she never saw. Now, again, at a trial, the young child said that she looked right at me. The woman looked right at me, but again, having never seen anything, her mind did not believe it was important information, so it never jumped her attention filter and got into her conscious thought process, so she never saw the young child, even though her perception brought it into her brain. And then we have the example of pilots who were so focused on a flashing bulb as they were landing that they never saw the ground coming up. But more importantly, they didn't hear an auditory alarm that was going off that said, land incursion, that everybody in the back heard, but the pilot and co-pilot did not hear. And that led to 100 people losing their lives, although there were quite a few survivors. And then we have the example in medication safety with many years ago, heparin was removed from an automated dispensing cabinet, and it was the wrong concentration for a flush, and it was used to flush lines in a NICU that led to the deaths of several infants. Some of that was confirmation bias, and inattentional bias is the broader umbrella. Confirmation bias is just one type of that, but it wasn't one nurse who didn't read a label carefully. It was more than a dozen nurses that never saw that it was the wrong concentration, which is explained more by inattentional blindness than anything else. They always saw the right. They always saw the right information on the label, and this time, even though they read the label, they didn't process that information in their conscious brain. So why does inattentional blindness happen? Remember that most of the information brought into our brain is processed outside of our consciousness. So we have this great capacity to bring large amounts of information into our brain, but our attention filter decides which information gets attended to and reaches our consciousness. So our experiences tell us what information is important and what information should be passed on to our conscious thoughts. It's called inattentional blindness because the information, although seen, was never consciously processed, was never reached the consciousness. So we consider our world to be what we see to be a true representation of our external world. But in reality, our brain is working with our eyes to construct the outside world inside our heads, and we use our memories and the knowledge we carry around to fill in gaps all the time. So we only see what our brain tells us to see, and we're inattentionally blind to the rest of the information, mostly because it never reaches our consciousness. Now, there's something called the grand illusion in human factors. If you do a search on that term, you'll learn more about it, but our brain is a master at filling in the gaps with pre-existing knowledge based on our past experiences. So I had an event that happened to me that really drove home this whole idea of inattentional blindness when I was in a salon one time where a person came in with a gun to rob the place. And he probably was there for about 20, 25 minutes. There were 7 or 8 of us in the salon, and this person harassed each person individually with the gun and took personal belongings, etc. When he finally left and the cops were called, we each gave an individual statement. And we each described the person who had come in with the gun. And every description was totally different except for the gun and the hands that held the gun. We all were in agreement on what the gun looked like and what the hands that held the gun were like, that the person wore black gloves. But everyone agrees that their description of the person who was robbing the salon is accurate. And they definitely saw hoodie, no hoodie, jeans, black pants, boots, sneakers, Southern accent, no Southern accent. Even the color of the person's skin was different. And the cops actually said that that is pretty common in even firsthand observations, and that they usually take just the common threads because that's the only thing they can count on. So this helps explain the grand illusion, where we were very focused on the gun and the hands that held the gun, and we filled in the rest of the information about that person based on our past experiences, our biases, etc. And we gave a description that we thought was very accurate. Of course, I think my description was the most accurate at the time. So there are a couple ways that we could reduce the risk of inattentional blindness. And the most important way is to make information as conspicuous as possible. So what you're trying to do is make important information pre-attentively processed within a matter of milliseconds. So it jumps the attention filter and makes its way into the consciousness without having to pass through that attention filter. So this is called pre-attentive processing. And the most important way to do that is to make the information that you want to be pre-attentively processed as conspicuous as possible. Contrast is the most important aspect of making information conspicuous from a physical property sense. So you can see that the text would be easiest to read if it's in high contrast with its background. You can use color. That's another way to make information as conspicuous and to make it as pre-attentive as possible. There's a couple rules with human beings with color. You should never use red or blue on a black background, because either the red or the blue text pops and not both. So most people will see the red text that pops out pre-attentively, but there's a small proportion of the population that will see the blue text. You want to make sure that you're avoiding conflicts with colors. You don't want to put a red sticker on something that is a go and a green sticker on something that you should stop, to warn people. We all have these intuitions about the use of color, and we want to avoid conflicts. For example, on the screen in the right-hand corner, if I were to ask you how many times the word yellow appears, I've thrown some conflicts in there for you, and it becomes very difficult. You would take quite a bit of time to actually get the correct answer, because some other colors are written in yellow text and the word yellow is in different colors. Now, when color is the same, when there's no difference in color, then shape can be a pre-attentive process to make information as conspicuous as possible. There's also ways to make information conspicuous from a cognitive sense, and that's to make it as relevant to people as possible. If you scan a newspaper, for example, you might have information that jumps out to you that is relevant. For example, your child's name. might jump out to you as you're just scanning a newspaper. This is making information as relevant as possible, and this was proven in a study called the cocktail party effect. The cocktail party effect is really the phenomenon of being in a very crowded room where the background noise, for example, at a cocktail party, can be volumed down to a buzz or a hum. It's really that unattended stimuli that you're not really listening to that conversation, but maybe you're listening attentively to a specific conversation with a very few people that are close to you. But as soon as someone across the room mentions your name, all of a sudden that buzz and hum jumps the attention filter and becomes important information to you in your conscious thought. So one way to make information as cognitively conspicuous as possible is to make it as relevant as possible. There's also, inattentional blindness can also be affected by workload and attention capacity. So you should try not to multitask. I know that's hard to say in healthcare, but it's certainly a human factors rule to not be multitasking. And then to try to fit people to the job as far as their attention capacity goes. Now, attention capacity is variable within individuals at certain times of the day. Certain people can be more attentive in the morning versus in the evening, etc. And then it can be different from person to person also. We might have people who tend to see the forest for the trees, or see the trees in the forest. And so we need the ability to pay attention to detail and also see the big picture in all of our life activities, but we usually have a propensity to do better at one than the other. So you want to make sure that the person who is checking your chemotherapy is a person who is detail-oriented, and the person who is overseeing all the processes in the pharmacy is a person who can see the big picture. So just making sure that the attention capacity fits the job. So let's talk a little bit about the working memory. Remember, this is where you're thinking and behaving. This is your conscious thoughts, and the process is called maintenance or rehearsal. There's a number of cognitive biases, these pesky glitches in thinking, that may cause us to make questionable decisions or err in judgment or draw inconsistent conclusions or incorrect conclusions or harshly judge others. And I've listed just a couple on the slides here. So just remember, we all suffer from dozens and dozens of cognitive biases, just as we do perceptual biases. This is little glitches in how we think about information once it gets into our brain. So we have the endowment effect, for example. And the endowment effect is when we place greater value on something after acquiring it, and it really plays a role in how difficult it is to affect change. We have the framing effect, for example. Sometimes we talk about how you spin the data. We often call this the consultant effect, where the director of pharmacy might suggest a strategy, but it's given less weight than if ISMP says it. So it's the framing effect and how you frame that information. It's the frequency illusion effect, and that is where things that were recently brought to one's attention now appear with improbable frequency. And we've seen this happen over and over again, where new staff members' errors have drawn some attention, and now you see their errors with improbable frequency and you think they're error prone. We all have suffered with hindsight bias, where our tendency is to see past events as being predictable, where we overstate and misrepresent a situation facing individuals at the time because we know the whole story. We know the right answers, and it tends to make us overreact, particularly to harmful events, and to harshly judge people who make mistakes. We have the normalcy bias, which we deal with every day at ISMP, where people say, oh, that adverse event would never happen here. So it's a refusal to plan for or react to an event that's never happened before, that you've never seen before, and the cognitive bias that it'll never happen with me. Unfortunately, there's too many that feel that way, and that the adverse experiences of others just do not apply. And we deal with that every day at ISMP. We have the identifiable victim effect. And this is where you have a tendency to respond more strongly to a person at risk than a group. And this is why storytelling is such a more effective way of affecting change than maybe presenting aggregate data or a policy or procedure. So we'll be talking a little bit more about storytelling, but remember this identifiable victim effect and our tendency to respond more strongly to a person or to a story of an error that has happened, and so it's more memorable. We have the status quo bias, or a tendency to like things to stay relatively the same. That affects our ability to change. We have this cognitive dissonance where we make up rationalizations for at-risk behaviors that we might engage in because they conflict with our values. So for example, if a patient talks about the appearance of their pills and that it looks different than usual, we might not follow up on it and just say, well, it must be the generic, or the patient must be confused, or a complainer, or the patient didn't sound very concerned. We make up all these rationalizations for why we didn't follow up on the patient's concerns about the appearance of a pill, for example. We have the current moment bias, and this really explains our tendency to act on behaviors due to the immediate rewards we get from them rather than seeing the delayed or uncertain consequences. So for example, we might cut a corner because we can get that job done sooner. We might work around a problem and not follow the way that the policy or procedure is designed to be followed because of a failure in front of us, and not see that it can lead to risk to the patient down the road. And then we have the outcome bias, where the tendency to judge a decision by its eventual outcome instead of based on the quality of the decision that people made at the time. And it leads to judging people based on the outcome rather than their behavioral choices, and it leads to the severity bias that we have in healthcare, where we're harshly judging people who were involved in harmful events. So we have all these cognitive biases that already set the stage for how we think about information. And just knowing about these cognitive biases do not necessarily make us not prone to them, but they also can give us some information about how we can overcome them and recognize that we're prone to things like hindsight bias when we're doing a root cause analysis, and recognizing that we have that propensity and bringing it to the attention of others when it plays a role in a root cause analysis. So again, there are a variety of both system and personal performance shaping factors that can degrade our working memory, that can degrade our ability to think clearly and make accurate decisions based on the information in our cognition. So those personal performance shaping factors arise within us. Those system performance shaping factors are external to our environment, our job aids, etc., things like that. And I've listed just a few of them on the screen here. We don't have time to cover all of the negative performance shaping factors that could impact our working memory, but I'd like to take a little bit of time to talk about environmental distractions and interruptions, since they happen so frequently in healthcare. So a distraction or interruption is anything that draws away, disturbs, or diverts attention away from the current task, forcing attention on another task. When I think of distractions and interruptions, I'm always reminded of an error that was reported to ISMP when I was a fellow several decades ago. It's still an excellent example of how easy it is to make a mistake when distracted. This error was reported with chloral hydrate liquid, which I know is not even commercially available at this time, but a nurse was pouring a dose of liquid chloral hydrate for a patient in a dosing cup and was walking down the hallway to administer that medication to the patient's room. She was interrupted by a pharmacist who began talking to her about another clinical issue, but then the conversation eroded into a social conversation, and the nurse and pharmacist were talking for quite a while about non-clinical issues. Now, this nurse always had a cup of coffee in her hand and typically sipped coffee throughout her shift. And because she had the chloral hydrate in her hand and was having a social conversation, she drank the actual chloral hydrate. I remember sitting with another ISMP student who was rotating through and saying, how could that happen? And it's just one example of how easy it is to become distracted, divert attention away from your current task, and just fall into the pathway of the automatic mode of transmission, automatic mode of cognition, and do something like drink the patient's medication. Imagine how hard that was to explain at that time. Now, there's also been a lot of studies with pharmacists and nurses related to medication examples. I am reminded right now of a study that was done about human interaction with computers. And it always reminds me of how we all fall victim to distractions and interruptions. So people were asked in this study to investigate or to search for a certain parameter on the internet, in the World Wide Web. And 40% wandered off in a new direction after they were distracted by something that they saw within the World Wide Web internet search. And they couldn't even remember what they were initially searching for. So distractions happen a lot to us. And they have done a lot of studies around nurses and pharmacists that have been interrupted as frequently as every 2 minutes during medication administration. There are several studies out there that talk about physicians, particularly ER physicians, that are interrupted once every 5 to 10 minutes. And then there are a bunch of human factor studies that talk about how you can increase the risk of a medication error by 12.7%, for example, per interruption. And that's doubled when a person is interrupted 4 times and tripled when they're interrupted 6 times, especially if it's a harmful event. So there's a lot of errors that can happen because of disruptions and distractions, interruptions. So which of the following do you think represents the greatest source of interruptions and distractions when nurses are administering medications? There was a study done that was observational and a survey, an interview tool that was used. And they asked nurses what their greatest source of interruptions were. And then they observed actual medication administration to see what those sources of interruptions were. Nurses actually said that it was telephone calls and patients that were their greatest source of interruptions and distractions during drug administration. But during the observations, they actually saw that the interruptions were self-induced by the health professionals themselves to initiate conversations or to gather materials that they didn't have that were needed for drug administration, missing medications or missing supplies that they needed for medication delivery devices. So if you want to reduce distractions and interruptions, I've listed just a couple ideas on this slide. The first two are, to create a no interruption zone or a, do not disturb signs. We're not big fans at ISMP of the do not disturb vests. They're overutilized and people become sensitized to them, and if you want to wear them during drug administration in critical areas like the ICU and a NICU, you're always giving medications, and so you never tend to take them off. And so, but there is some evidence out there, and we put it on our slide because there is some scientific evidence that it does reduce the risk of making medication errors. However, we're not so sure that it was sustained even in those studies. So we do know that there are best times for necessary interruptions between subtasks, so between patient administrations, between preparations of different products, because one of the problems with distractions and interruptions in healthcare is that some of them are very important. If you're interrupted because of a medical emergency, of course you need to be interrupted. If you're interrupted because you need to be told what a certain lab value is that relates to a medication that you're preparing or administering, then you need to be interrupted. So there are best times for necessary interruptions, and those would be between subtasks related to medication administration. We highly recommend that you use checklists during critical tasks so you can remember where you left off. Studies have shown that people tend to repeat steps rather than skip steps when they go back to a task that they've been interrupted in. So they might repeat a medication administration as opposed to skipping a medication administration when they're interrupted during the process. So a checklist can really help. Make sure that you're gathering all needed supplies before you start. Make sure that you're taking care of all system issues such as missing medications, and then remember that distractions and interruptions, and again, we don't have time to talk about these, but these are very important to have some type of mobile device management strategy and to reduce invalid alerts, alarms, and noise to reduce alarm fatigue or alert fatigue. So let's talk about the long-term memory a little bit. Remember, this is where we store all of our memories. So it's our data storage area, and we're trying to retrieve them when we need them. Again, there are a lot of personal performance shaping factors and system performance shaping factors that can degrade the long-term memory. Certainly things like interference with the retrieval process, or the quality and the interest of the educational experience, the intelligent aptitude, can all affect how we store memories. But so does our motivation to recall those memories. So did you ever try to remember a name or a place or some specific piece of information, and it really bothers you that you can't remember it, and hours later all of a sudden it'll pop into your conscious mind? Remember, that's your long-term memory, which is kind of like the hard drive, trying to do a search in your long-term memory stores to find that information, and hours later, after you no longer need it, it pops into your memory. It pops into your conscious thoughts. The interesting thing about the motivation to recall, if we're really motivated to recall and it pops into your conscious thoughts hours later, our brain is smart enough to know that it took too long for that memory to be retrieved, and so we recode it automatically so that it's easier to retrieve the next time. So you shouldn't have as much difficulty remembering that piece of information, because it's always recoded when hours later it pops into your mind. I also want to mention that memories can change as you retrieve them. Remember Uncle Barry's fish story, where he caught a fish that was 1 foot long, and by the time he's done telling the story years later, that fish is now 2 feet long. So as we tell stories that we retrieve from our memory, we fill in gaps in that story with information that may not be accurate. So memories can change as we retrieve them, especially if we tell them over time. And it's very easy to instill false memories. So remember, memories are the sum of all that we've done, all that we've thought about what we've done, all that we believe, all that we've been told, and all that we saw, etc. So it's very easy to instill false memories in people. There's been quite a few studies, for example, where they have tried to instill false memories in children and adults. One study that comes to mind had to do with the going to a mall, getting lost in a mall, and that falsehood was introduced into people's stories, and they were given those stories, and almost all the children agreed that they were lost in a mall, and made up vivid stories about it. But about 60% of the adults also agree that because family members thought they had been lost in a mall, they had a memory that they were lost in a mall. And they actually came up with pretty detailed stories about how they got lost in the mall and what that felt like. So it's pretty easy to instill false memories into people. It's one of the reasons that we tell people that when you're interviewing people during an vet investigation, you should interview people separately so that you and listen rather than sharing information, so that you can get the story before you possibly could instill any false memories in those people. So one of the best ways to enhance memory is through storytelling. So storytelling helps expose dilemmas, enhance attentiveness, incite questions, and challenge assumptions. But more importantly, those stories are usually very memorable. And lessons without stories rarely lead to learning or to change. So people remember memorable stories, and they can remember a reason for changing their behavior or for implementing a specific medication safety strategy. It opens them to new ways of thinking about information. And I can assure you that a story about a little boy who chewed on a fentanyl patch he picked up on the wheels of his toy truck while visiting his grandmother in a nursing home did a lot more to incite change into checking placement to make sure that the patch has stayed in place and proper disposal of patch than any data that we could have presented or any policies, procedures, or edicts to make sure that you're careful with the disposal and checking the placement of those. So those memorable stories are what people can kind of relate and link to any type of change that you're asking them to make in their behavior. So I'd like to end with maybe 10 minutes, 15 minutes discussion about how you can use human factors when you're designing your systems. And first, I'd like to describe a bad system design, either in everyday life or in medication safety, and then talk about a better system design strategy based on human factors research. What has higher leverage? What types of strategies would make for safer medication use? So first is a bad design, things that don't work the way you expect. So if you approached a door that had this type of a handle, you would tend to pull it. And you get into the vestibule and you would try to pull this door, and you would find that it's locked because maybe the store is closed, and you'd come back and you would pull again at this door, but now you have to push it to open it and you'd be stuck in the vestibule. So initially, when you approach this type of door, this type of a pull would indicate that to most people that you pull it. So things that don't work the way you expect them to work can cause errors. So a better system design or a more reliable system design uses affordances. Affordances include those intuitive design features that help communicate their correct use. So pushing a button to turn equipment on or off, or turning a knob right should produce a corresponding movement to the right. So you don't want to tell people to toggle right to turn left, or you don't want to package a concentrated product in an ampule, which is typically used for ready-to-use product. So you want to identify affordances up front, and that's usually done through usability testing or some type of heuristic evaluation of processes to make sure that they're intuitive, that they're what people would think. You know, I hate traveling to hotels throughout the country that have different alarm clocks or different showering systems where you just can't figure out how to work it. And these are because they are not using intuitive design or affordances. Things that are hard to remember, like which side your gas tank is on when you want to fill it, or things with too many choices. We have a lot of that in healthcare. So a better system design would be to standardize and to simplify. So standardization reduces the reliance on memory and helps you implement some best practices, some evidence-based best practices consistently in the medication use process. And then simplification reduces the workload on the brain because each additional step in the process adds a cumulative risk. So I'm sure you've all seen those ideas where if there's a one-step process that might have a 1% rate of error, and if there's a 50-step process, it will have a 50% rate of error. So reducing the number of steps, simplifying it, and standardizing it. Now, simplification does not mean to simply remove value-added steps, just so it has less steps. So you want to remove waste and non-value-added steps, or you want to totally change the system so it has less steps in it. So I've given you some examples here. You can use commercially prepared products that would simplify and standardize concentrations. You could use evidence-based standard order sets that could both simplify and standardize the care given to patients. You could standardize concentrations, containers, sizes, drugs, dispense unit doses to simplify the preparation process and utilize dosing charts, etc. Just some examples of how you can simplify and standardize medication safety. Unlimited access is a bad design. Here is a picture of a 24-hour supply that is changed out every day for anesthesia. You wouldn't need all of those medications in a 24-hour period of time. Or bad design, things that are too easy to grab by mistake, conditions that make it too easy to grab. This is a neuromuscular blocking agent in a dark refrigerator along with diltiazem. A better design strategy is to limit access to just what is needed, to limit access of high risk or high alert products to qualified and trained practitioners, to externalize and centralize the most error-prone processes to reduce the opportunities for errors. So we have a couple examples here: sequester neuromuscular blocking agents, prepare all chemotherapy in a centralized location, require special training for access, prescribing, preparation, dispensing, or administration of high alert medications to kind of limit those to qualified and trained individuals, to limit access to concentrated oral solutions, opioids, and to carefully select the drugs, concentrations, quantities, and floor stock, etc. Different things or names that are too similar. We certainly have a lot of lookalike drug names and packages in healthcare. The best strategy is to test those names and packages up front so we don't have lookalike names and packages. But that's not the reality. So the better design strategy is to differentiate these lookalike packages or to affix warnings to them if there's some component of that package that looks too similar to others. Examples might be auxiliary labels for chemotherapy, neuromuscular blocking agents, powerful opioids to draw attention to it, to use color to draw out warnings on labels, and then to totally differentiate them, drug names by using tall man letters and purchasing lookalike products from different manufacturers. New equipment with unexpected functions. This is a very bad design. An example would be a lever that is in front of a seat in a automobile. This lever was mistaken as a lever that could push the seat back or pull it forward, and instead it releases the seat totally, and it has caused several accidents. A better design strategy would be to proactively conduct a risk assessment before purchasing use of new equipment, new drugs, new processes, to identify potential failures, to take action, maybe to purchase a different product, a different drug, or set up a different process, or at least to address those potential failures up front. Machines that do what you don't want them to do. This is a bad design, an example of an old car many years ago that you could start without engaging the clutch if it was a manual transmission, or putting the car in park if it was an automatic transmission. And so you might need to, car industry change that design so that we now have a forcing function in place to engage the clutch or to put the car in automatic transmission before you start it. So obviously the better design factor is to create barriers, forcing functions, or fail-safes, design them into your systems to prevent the hazard from touching the target. Things like personal protective equipment, needleless systems, forcing functions like medical gas connectors that are different, oral syringes that won't attach to IV syringes, or even fail-safes like free flow protection with infusion pumps. Conditions that make it hard to find information, whether it's policies and procedures or information about new patients, etc., or about drugs. Information can be such a powerful tool, but it's only if it's readily available, easily found, just in time, just when you need it. So you want to improve access to information, either through making sure you have the right team members, so getting clinical pharmacists out to patient care areas, or using technology to improve access to information. And that what you don't want is a single pathway to serious harm. You don't want to make sure that you're only one error away from a very serious hazard. When that happens, what we tend to do is build in a redundancy, a multiple pathway. So if the first fails, the second is successful. So you might have things like read back or automated redundancies, or requiring patient identification using two unique identifiers, or marking the surgical site. So any type of redundancy that's done in parallel. And then we have recovery. Recovery systems allow the error to happen, but relies on the ability to detect the event before there's an undesirable outcome. So things like capnography for patient monitoring, timely assessments, labs, review screens on pumps, and just capture prescribing, dispensing, and administration errors through downstream checks or tests would be an example of recovery strategies. So we have a rank order of risk reduction strategies. Those with the highest leverage target the system. Those with the lowest leverage target the humans. The system is called the blunt end. The human is called the sharp end. So what you want to do is make sure that if you're using something like education, information, rules and policies, even reminders and checklists, make sure that you're bundling it with additional strategies that have higher leverage, things like standardization, redundancies, high-level redundancies, barriers, fail-safes, forcing functions, just making sure that you hedge your bets and layer your risk reduction strategies to make sure that you're not relying on a single strategy to reduce the risk of an error. Okay, I think we're ready for questions.
Yes, Judy, boy, that was absolutely excellent. Absolutely excellent. Thank you so much for putting all that together. I think everybody that was listening had to learn. We had over 800 people that were actually dialed in. We had several thousand actually, well, over 1,500 actually that, told us they were going to sign up. And that it always seems to cut in half, but you had over 800 people. They were from all continents of the world. It was really great to see everybody from all over the world joining and making a lot of comments themselves, adding a lot of things on their own that were very helpful. But we did have several questions about the table that you showed at the beginning. And that was actually, I found that, Judy, in an article that you did with me. And it was, I put the reference on the chat. That was from the STPRA article that we did for the Journal of the American Pharmacists Association back in 2012. The reference is in the chat box. And that was a real effort that you did. You must have reviewed, I don't know how many, 40 or 50 studies to get that done. And there were, so it wasn't from
so you're talking about the table that talked about the rates of error?
Yes.
Right, yeah.
Error probability, correct.
Yeah, we have tons of those tables put together. So that reference would be a great reference, Mike.
Yeah, I sent that there. Another thing was people wanted to know about what our recommendations would be for, warnings, safety alert messages, medication safety postings, etc. As far as white space, font, bolding or not, use of color. So I checked that out too. And we did have a couple of references that we posted on the chat for that as well. People will check it out. We did one called Your Attention Please, Designing Effective Warnings that covers a lot of that. And we did another one on color and patient safety. which covers some of that as well. But Judy, we did have a question, and that was how can we educate our teams about the various cognitive biases you spoke about in response to medication events? And I was thinking, is it important to educate the staff about that, or is it important to educate supervisors about that so that they know how to properly handle these system-based causes of error?
Well, I think people that know about cognitive biases understand why we draw incorrect conclusions, why we make judgment errors, etc., why we harshly judge other people. And I think it helps individuals not finger point at other people and helps some of those blaming attitudes. So I think it's important to educate everyone about how we're fallible, why we make mistakes, and some of those cognitive biases that we all fall victim to. But I agree that it should be the supervisors who receive the education first, because they're the ones that are asked to sit in judgment of those who make mistakes.
Absolutely. And I don't want to forget to thank Novartis again, their name creation and regulatory strategy. They really care about their products being used safely, and they recognize they have a responsibility to promote safety in the field as well. And thanks to their support, we were able to put on these programs. This is our third one we've done on an international level, and we don't have to charge for it. And it's absolutely amazing that they do that. And it's totally free of any commercial link with any products at all. So we thank them for their support. And Judy, there was another one. Do you remember in the warnings article, the signal words, how some might bring things to a higher level in one's eyes than other signal words?
Yeah, I think the word danger, caution, and the use of red and yellow are described in that article. And they each bring a certain level of warning, because danger, we all know, warning is not as prevalent, and it describes when you should use both of those. And if you misuse danger too often, you're going to dilute it. It should be saved for the most dangerous types of warnings. So we did cover that in that article. I'm just not remembering exactly, but I do remember talking about the difference between some of the terms and the use of some of the colors.
Right. By the way, we have a newsletter, and it is a subscription newsletter, but we do put the main article on our website for free, and all the references that I gave you on the chat box are available for free. But we do hope that you'll consider subscribing to the newsletter as well. There's a lot more information in there than just the main article. So we do a lot of our alerts. In fact, one came in just recently, and it had to do with the way, and you were talking about this a little bit, the way the concentration is expressed on a label. And it was a 10 milliliter vial of drug. And I can't remember exactly what the drug was, so I'm not going to say that, but it doesn't matter. And it said 10 milligram per milliliter. And that's all it said. It didn't say anything else. And someone picked up that vial thinking it was 10 milligram. And in fact, it was a 10 milliliter vial. So it had more than 10 milligram. It had 100 milligram. That's pretty obvious. How does that jibe with the inattentional blindness? I think you were talking about something like that right around that time.
Yeah, I think inattentional blindness and confirmation bias are, confirmation bias is one type of inattentional blindness, but I think someone who is used to seeing the total amount of drug in the vial and then encounters a drug that is listed as primarily the dose per milliliter, is going to be confused because of inattentional blindness. Or at least be confused based on other parameters of human fallibility, and not necessarily just that they misread a vial. So they might not see any disconfirming evidence where the total amount is somewhere on the vial if it's not right where they expect it to be.
Right. And in the United States, and we were surprised to see this because it's, not the way the vial should be labeled. So we did report it to the company and also to our FDA. But in the U.S. now, we need the total amount in the container as the primary designation, followed immediately by the amount per milliliter. So both pieces of information are on the label. So that's it. It's 2 o'clock here in the Eastern United States. The program is over. Judy Smetzer, you really did an awesome job, and I really, really appreciate it. We all appreciate it. I think everyone learned a lot. Again, thanks to Novartis. And please, if you go to our website, sign up for our messages so we can let you know when the next program will be. Thank you very much, everybody. And thanks for joining us today. Bye now.